sponsored by, it's being co-sponsored by the UCLA C-LARA, a new center focused on LGBTQ health, and also Queers for Public Health and the Reproductive Health Interest Group. Take it away, Sue.
Thank you. Hi, everybody. Again, my name is Susan LaVaccare. Thank you, Frankie and Paula. Thanks, everyone, for being here. I don't know, this may be very basic for you. This is an introductory presentation curriculum, just around focusing on the lesbian, bisexual, queer women aspect of the LGBTQ community acronym. And it's a little bit about health issues and tips on how to communicate as a way to be open and show a way of being a safe harbor and a support and advocate for LGBTQ people so that they can get the best care possible, whether that's as a public health provider, a medical practitioner, a social worker, etc. So I'm going to share my screen and go through a PowerPoint. If there is any questions that you have, sorry, let me first do this. If there's any questions that you have, of course, it's not working. It didn't work out, right? I will answer them as we go along. So let me know if you have any questions, and I will, this is not working either, sorry. Somebody's in the waiting room. I don't know if somebody can, there we go, thank you. Hold on, why is this not working? There we go, excellent. Just took a minute for some reason. Okay, have any questions as we go along? Let's make this a dialogue because it is pretty basic, and you may know a lot of this. You may have comments, you might have discussion. So I know we have about 45 minutes. But if someone also, Frankie, could you be like monitoring the chat, and if there's some highline things to bring up, if you could let me know. Like I see something in the chat now, but I'm not actually looking at it. That would be fantastic. So I don't know if this is going to keep popping up, but I think it's fine. Okay, so overall, what we do is we're a collaborative that was started by the LA County Office of Women's Health, the City of West Hollywood, and then we brought in UCLA Iris Cantor about a year or two later, the LGBTQ Center of LA. We have representatives from USC and several of the Cal State universities, UC Santa Barbara, obviously UCLA, and who am I missing is a big other partner. But so we've been around since 2007 is when we started, so a long time. And we present to a wide variety of groups. I was telling Frankie before y'all came on is that I used to work at the School of Public Health at UCLA. I was in that red building, the main asbestos-filled building. I think it's still there. Working in nutrition with Dr. Prelip and Dr. Newman, Charlotte Newman, and Dr. Slusser as my PIs, working with LAUSD schools, CDC-funded and Blue Cross-funded research. That was really one of my only forays outside of the LGBTQ world of health and research. So I've spent many hours in probably buildings that y'all have been in, and Bixby is very familiar to me as well. So I'm glad to be back. I actually did one of these trainings around our nutrition research when I was there years ago. Training outcomes, we're just going to talk about, let me help myself to get out of there, we go, to talk about ways, issues around LGBTQ women seeking care, and suggest some best practices based on research and qualitative and quantitative research. Understanding the importance of intersectionality and why thinking about all these issues is going to improve client outcomes. Discussing, so there's 3 different trainings we do, by the way, and I'm giving you the more social service. I know you're public health. We have a medical that's a little bit more healthcare practitioner focused. We have an administrator, and there's a social service. They're all quite similar. They're just a little bit different. This one is technically the social service one. And then we're going to discuss a little bit about mental health, substance abuse, in terms of, again, research showing numbers. probably very intuitive when you see those numbers. And then identifying some practical ways you might be able to make sure you're open to and lifting up and supporting LGBTQ women, however you interact with them. Why is this happening again? Okay, there we go. Questions to consider. As we're going through, you might want to think, and especially before you do whatever you're going to do, if you're going to be frontline person, you're going to be a researcher, you're going to become a professor, whatever you're going to do, is what are the challenges that might face LGBTQ women as they try to encounter really any system, but here we're talking mostly about healthcare. That could be mental health, physical health, public health, going to a hospital. What types of challenges might be unique to LGBTQ women? And what are unique health issues? And we're going to find out not really any, but just give you some stats on health issues that LGBTQ women face. What are some ways that you can play a role in addressing and reducing the challenges? And then what are some ways that you can help promote open, trusting communication with LGBTQ women? And think about, why do you think it might be difficult for LBQ women to discuss, come out, be open about their sexual orientation, their sexual health, their gender identity to people in power positions, healthcare providers? I am jumping like 2 ahead, aren't I? What's happening here? There we go. Okay. Here's some basic definitions that are just, they're basic science definitions. There's lots of ways to define sexual orientation, gender identity, which are 2 separate things. Within sexual orientation, it's sort of an umbrella about thinking about, again, one's romantic, emotional, sexual attraction to other people. And then under that general orientation would be labels that our society has come up with. Some people take those on, those labels, and some people don't. So to help identify what do those labels mean, possibly, they might not mean this for everybody. So your best bet is to inquire further about specifically what they mean, but this is a good indicator of where they're heading. If they use these labels, gay or lesbian usually means an emotional, romantic, or sexual attraction to individuals of one's own gender, whether the person's transgender, cisgender, attraction to another person of that gender. Bisexual can be defined as emotional, romantic, or sexual attraction to both men and women, and that is binary. And then, which is binary, bisexual. And then there's terms like pansexual, fluid, that would be emotional, romantic, sexual attraction to people of any gender identity. Queer could also be used in place of fluid or pansexual, or just a general label that these other identities and labels don't fit for them, and they've taken on the queer label. And then there's definitely many people who don't have any of these labels, may have their own unique label, like same gender loving, or women have sex with women, or men have sex with men, or down low, or et cetera, or no label. It's just part of who they are, their attractions or their behaviors. And so that all fits with under sexual orientation. And then separate, just like brown hair, blonde hair is different from right-handed, left-handed. Those are 2 kind of characteristics of humans. Sexual orientation and gender identity are 2 completely separate things of a person. And gender identity and expression is more around a person's deeply held internal sense of their gender, male or female, or somewhere on that continuum of gender. So their own identity. And then gender expression would be how they show expression, whatever that is, whether it's cisgender, transgender, just how do we express, like society has set up ways that we express our gender. Some we don't even know we're doing, and others we purposely do. So it might be the way you dress, it might be a person's name, their pronouns they use, their grooming, the length of their hair, do they wear makeup or jewelry, their mannerisms, how they talk, their speech patterns, who they interact with, and their social interactions. So their identity is their belief, an internal sense of themselves, and then the expression is how we move about and show the world. And again, oftentimes subconsciously, our expressions.
Sue, there's a
Yes,
question from the audience in the
yes, please.
chat.
Okay.
So in the chat, someone has written, queer is a word I've heard as negative and some say no.
Yeah.
Yeah.
So it feels that nowadays, not so much. Yes, for many, many years, queer was a derogatory word. Then there was a phase where it was like, well, don't use it because let the person use it that identifies with it. You don't use it. I feel like we've definitely moved towards it's become part of the acronym. So LGBTQ, obviously everyone is unique. And so your job when you're working one-on-one with a person is to, that's what the end of this presentation is about, is communication skills and how to figure out and be open to and solicit from them who they are and what they prefer and be respectful. But I think the Q has now become equally to the LGBT, that it's not so much a slur or negative any longer. That's my assessment from this work for several years and seeing it change. Like I could go back to that. It used to be like gay and lesbian, right? And then it was LGBT, and then it, so like the acronym has changed over the years, and the Q is pretty much there now. So therefore, it doesn't have that connotation. Could it be used in that way? Well, so is the word gay, right? That still happens in schools, that it's used in a negative context, right? Or it's used in some places where someone says, that's so gay. But that's when someone says, I'm a gay man or I'm a gay woman, it's just the context. So I hope that answers the question. I do think that's evolved over time. It did used to be a negative word. Cisgender, transgender, non-binary, fluid. So gender identity, we talked about, is a deeply held belief. And so again, science researchers put these in categories. We have labels. Lots of people don't use labels, but if they do use labels, some of the general labels are cisgender, same gender. So you're born, a doctor says, it's a boy, it's a girl, writes it on the birth certificate, often just by an assessment of anatomy. Usually that's the case. Some occasional by genetics, if there's some question of the anatomy. It's that simple. The power is given to that provider, usually a doctor. And then a lot of people go along life and they feel over time that their deeply held belief about their gender matches what that doctor assessed and put on the birth certificate. Then there's people who their deeply held belief could be by age 3, could be by age 4, age 11, age 60, age 70. They know internally their belief is that what that doctor or that provider assessed or put on the birth certificate is not me, doesn't match me. This is who I am. And so trans, it's different, it's other, like you trans moved over, it's not same cis. That's really the difference between those two. And trans is an umbrella term that could mean some, a wide range of things, but it's mostly about what I just said. It's that a person does not feel knowingly know about themselves that they are what the society has said is this binary gender. They may say, no, I'm fluid. I want to dress. I might want to physically alter myself. I might not. It's sort of an umbrella term for, but I know that I'm not what was written on my birth certificate in the way that society means that. So it's a little vague, but it's an umbrella term. And then, like I said, there's many people who, and it's more and more common, millennials and Gen Zers have really come out and have more confidence. And there's new research that's looking at this about non-binary, gender queer, gender fluid, none of the above terms around just being themselves, not boxed, not binary, not male, female, on a gender continuum. They just know that neither one of those fit, or some of each of what our society has said are characteristics of genders are, and they feel like they're more than one. And so individuality, choosing labels, and that's common and will become more and more common as the research is showing. Okay. So why do we care? Why should you care? Is that we did a bunch of focus groups, and one young woman in my children's hospital focus group said that it's forgotten that we're part of the LGBT, meaning women, young women. It's forgotten that we're part of the LGBT acronym. Women in general are invisible. and then add in the attraction to women piece, and we're doubly invisible. And later we're going to get into add race into that, or economic status, and then there's triple, quadruple invisibility. So when we're going into, sorry, I just want to make sure that we're going into thinking about gender identity, sexual orientation, why this is important. Another thing to consider is when we're talking about the sexual orientation part, what one's label is, what one sees as themselves, their orientation, that's one thing. What their behavior is physically, sexually, is not necessarily what you assume the label of a sexual orientation, sexual behavior is. So you may think, oh, this woman identifies as a lesbian, therefore, based on what I know, I'm going to assume she has these types of sexual behaviors. Well, that's a very erroneous assumption to make, because really, right, people are free will, they could do whatever they like, and they can also have an orientation identity. Very often, again, research shows that they don't match. And I'll show you in a minute some actual numbers from federally funded studies that make sure you're asking about sexual behavior, even if you know someone's label or you know who they're in a relationship with. And I actually have phrases in here, and I think the fact sheet that will be sent to you are going to give you more suggested phrases of how to ask in an open-ended way, and also in a way that the patient or client understands why you're asking. So behavior may not be congruent with what you assume someone with that sexual orientation label would be. And you can't assume the parameters of sexual behaviors based on, again, their relationship status or their identity. So now we're starting to get into some numbers. This is from the National Survey of Family Growth. That's been going on for a long time. It's a very robust, large sample size across the country, federally funded study. And in 2016, 1.3% of women in the US identified as lesbian or gay, 5.5% identified as bisexual. And then, no, that's too far. Why did you go to? There we go. One more. There we go. So we have those numbers of the 1.3 for gay or lesbian and 5.5 for bisexual in terms of label or orientation, self-identified. But then they asked about behavior, and 11.7 said that they had a same-sex partner in some way. They had some kind of sexual behavior with someone of the same sex just in the last year. So 1.3 label themselves as gay or lesbian, 5.5 say label themselves as bisexual, but 11.5%, more than that, are having some kind of sexual behavior. In their lifetime, 17.5% are having some kind of sexual behavior. This is actually increased in terms of people acknowledging this. I'm going to quickly go here, not here. I'm going to move this out of the way. Can I move this out of the way? This. Okay, so this is the Gallup poll. Did everyone see this? This just came out last week. I'll get to the title so you could see it, and you can look it up if you want. LGBT identification rises to 5.6 in the latest US estimate. This is not the same study. The other study that I just told you about is a really nice, robust sample size, a very reliable, ongoing study. But this is Gallup's updated research from 2017. And as you can see, the number of people in the general population is just rising of LGBT identification. Does that mean the number of people is getting bigger? Or does that mean that more people are willing to acknowledge their attractions, behaviors, orientations that fit in the LGBT acronym? And that's for us to continue to assess. I would bet it's the latter. It's not that there's more. It might be both, but we don't know. But we do know that the numbers are increasing. And the takeaway that we've always known, but is even greater, you know how I just showed you 1.3 say lesbian or gay, 5.5 say bisexual. We're here, again, it's reinforcing an even a larger number, that majority of the people within the LGBT identify as bisexual. And that might also be why the numbers have been lower in the past, because there's a lot of research and more qualitative study that would show that if you're with someone of the opposite gender, it's just easier to let people assume you're straight and not talk about that you're bisexual. And so the numbers have been suppressed, and that the newer generations, younger generations, are just being more open about the fact that they are attracted or have had behaviors, sexual behaviors with all genders, both genders. And so this research is just amplifying that even greater than what I was just showing you in our PowerPoint presentation. So this is a nice study to look at, the results of that study. And as you can see, the LGBTQ identification is not uncommon in the younger generations. And look at that huge, what a jump as we're going through the generations. Baby boomers, this is of the general population, how many identify in the LGBTQ category. Gen Z, 16%, 9% millennial, 4% Gen X, 2% boomers, 1.3 traditionalists. And then within the breakdown, again, just showing you within the generations, again, just showing how bisexuality, the bisexual label orientation is the greatest of within the acronym. Say, now that you're identifying in LGBTQ, which one do you choose fits you best? And in all cases, most of the cases, I should say, bisexual is the greatest, except for you could see boomers. It's gay. So I'm going to go back. But anyway, so you might want to go look at that study. There's some other fun details in there. Okay, but that kind of reinforces what I have here. So kind of to summarize this, these concepts are all on a continuum, right? There's nothing binary. I think we've learned that over the years, that again, sexual orientation, sexual behavior, sexual attraction, that's one type of part of who a human is. Gender identity, sex assigned at birth, gender expression, another part, characteristic of who a human is. And then there's relationship preferences and status. And just to remind yourself not to make assumptions based on any of these, just because you know who they are identifying as their partner, what label they use as their orientation, what their name is. That doesn't give you all the information, and your job is to be open, have good communication skills, to solicit more information and present in a safe and trustworthy way that they trust you to share that information with you in whatever your role is. So, oops, geez, just a little slip of the hand and it goes forward. Okay, intersectionality, who are LBQ women? They're everybody, right? All races, all economic levels, all income, all education levels, ages, physical abilities. So you got to remember this, no matter who you're interacting with, religions, housing insecure, how they dress, who their partner is, and also transgender people, right? Because that's separate from sexual orientation, can and are of various sexual orientations and vice versa. And if there's any questions that I'm not noticing, please let me know. So another interesting thing to consider is that if you are dealing with people, which we all are, where English is a second language to them, and you are dealing with either yourself as a translator, a family member as a translator, you're hiring an in-house translator, you call a translation service on the phone, is that traditionally, someone brought up as queer is derogatory. A lot of languages, when they translate the LGBTQ words, they often are derogatory words. And this has been looked at. There are some resources that have come up with terms that help translate it in a respectful way, but that is something to consider. Is also if you're translating pamphlets or posters, you know, to make sure that you're having those translations vetted by people so that the words that are being chosen in the translation are respectful and accurate. So here's a little bit more about, you know, how I said before, like there was that quote about where women are invisible, and then being a LGBT women were doubly invisible. And then I brought up triple and quadruple. So LBQ, racial and ethnic minorities, are at even greater risk for stigma and discrimination, as you might imagine, often within their own communities. There's discrimination related to race, to gender, sexual orientation, each of those, and then compound that. And then often, sometimes is the case that within their racial or ethnic community, there's homophobia or discrimination, biphobia, transphobia, discrimination about their gender identity or their sexual orientation. And then within the LGBTQ community, there's racial or ethnic discrimination. So studies have found that sometimes providers have framed, as we know historically, the DSM is an example, right? The American Psychiatric Association for years and years and years labeled people's sexual orientation that was not heterosexual as pathological. And because of that, that causes distress for people who know that they're attracted to people of the same gender or more than one gender. It causes a lot of stress and distress, and could lead to ways that they try to cope in life. And we'll get in a minute, it also can cause some internalized hatred. And then you've probably heard of reparative therapies, and our US Representative Ted Lieu, you have him to thank that on the state level, he's the one who got passed in California. I think at that point it was the 8th state. I think we have about 15 states now that have laws that say it's illegal to get paid and get reimbursed or having like an actual institution reparative therapy as an actual real legitimate form of therapy. And this is where someone seeks out a therapist whose job it is, who knows that they believe that something's wrong with you if you're not cisgender heterosexual, and they're gonna cure you with these different methods called reparative therapy, which has been proven with lots of research is severely damaging to the people who have either been subjected to that by their parents or themselves seek it out of internal phobia, maybe because of their religion and so forth, causes greater damage to those people for the most part. LGBTQ women report a reluctance to access care because they've had experiences being discriminated against. They see these signs of discrimination, and so it just takes them longer to go in because they've had negative experiences in their past around who they love, what type of sexual behaviors they have, just their attractions even. And even when they're given the opportunity, it's still hard to talk about their sexual orientation because again, there's negative experiences that they've had in the past. But if you can be that trustworthy person and offer good communication and signs, again, like literally posters or pamphlets, they will come to understand, because just like in other ways, people who have less power in our society are looking out for who are their trusted people, hypervigilance, LGBTQ people are doing that too. So if you can offer that to them by what you say, again, your practices, again, how your office looks, what's in your office, then people will begin to open up and trust you, and then you can give them the best possible care that they deserve and that you want to provide. The other thing about what happens is, because again, you're public health people, you want to make the world a better place. That would be an assumption I'm making, that you're going into this field for that. And so if people feel afraid to tell you who they are, feel afraid to tell you who's their intimate relationships, are afraid to share what their sexual practices are, then you are missing opportunities to educate them, to support them, to help lift them up to live their best life. And they are very often missing opportunities to be supported, to be educated, to be cared for, because there's barriers either in your institution that maybe is not coming from you, or coming from larger society that they're putting on you and assuming that you're also going to be like that. So it's your job to be, again, be open and present in a way so people know that you are open to everybody. So a little bit deeper, we're talking here more specifically about practitioners. They've actually studied, this is more directly with medical providers, that there's been actual research that shows that heterosexual providers have a moderate to strong implicit preference for straight clients versus LGBTQ clients. And that many, they interviewed a bunch of LGBTQ physicians who said that they've observed their colleagues, whatever their orientation, discriminating against LGBTQ patients. So there is a felt stigma that's real by clients, because there's enough of the bias that providers, it's subconscious, they don't even know they're doing. And that's why we try to talk about it, we try to educate, we try to give people just some basic information so that they can now take it back and talk with their colleagues or their mentor or their supervisor to hash this out, so that when you are dealing with clients, you can be, again, the best provider possible in whatever type of provider you are. So here's some pitfalls in caring for LBQ women. Again, sort of wrapping up what I've talked about is that heterosexuality is assumed for various reasons, how they dress, just because you don't even think about any other possibility of a relationship status or sexual behavior. Did I say that who they're in a relationship with? So they might, if we're talking about LBQ women, they may talk about a man as a partner, does not mean that they're heterosexual. It might mean that, and that's just for you to find out. The other things that often are pitfalls is that we forget about the community. And I think this is common as well in other parts of our lives, is that sometimes people's best support systems are their friends. They don't have a family who loves them and accepts them for who they are. And also in terms of, let's say, if it is even mental health or physical health, is that your job is to find who's their best support system, because sometimes it's the support system that's going to help them take their medication, stay on their exercise program, not lean to that alcohol that they're trying to stop using. And so you help to identify who is their true support system without assuming it's XYZ, because it might be another woman, if we're talking about LBQ women, who's actually her partner, but she hasn't really told many people that because she's had negative experiences in the past. Other pitfalls may be, again, that you make assumptions, and so behaviors and identities are not commonly addressed because you're assuming one or the other. Like if they are telling you about their sexual behaviors, you might assume a sexual orientation that might not be accurate if they haven't told you how they perceive themselves. And then because of that, you may miss really important risk assessments, right? So you may think, oh, it's a woman having sex with women. From what I know, she's not at risk for HIV. Well, that's actually not accurate. You'd have to do kind of a more calculation, and you have to find out what are her sexual behaviors. That's just one example. There's many examples. Other examples would be cancer risk or heart disease and so forth, mental health, et cetera. And then assuming over or under assuming what their health risks would be. Again, I just brought up cancer and HIV. They're right down there in the middle. Another thing that happens a lot is that you remind yourself to talk about confidentiality with everyone. Remind them that everything you talk about is between the two of you and that they can trust you. And you're gonna have to show them that as well as say it. But oftentimes we forget, we're rushing, or you think it's a given. That what you say is going to be kept in confidence, obviously, except for mandating reporting. So then this is a little bit changed now, but it used to be very common that if a woman presented that she was a lesbian and she was in a relationship with another woman, that they didn't have kids, they aren't going to have kids unless they had kids from a marriage to a man. And as we all know, that's very different now. So again, you don't want to make assumptions about that. There's lots of two women couples who are planning kids and have kids, as well as men, though we're talking about women here, as well as transgender people. I have a colleague who I've known for years, you might have heard in the news, who is a transgender man, was biologically assigned at birth as a woman, and has given, I think, birth twice as a trans man. So those are just things like to not make assumptions about who they are. It's all about asking and communication. It's kind of the whole theme of this whole thing. Some other barriers to healthcare utilization that maybe changed a little since ACA, but not totally, is lack of healthcare insurance. ACA is actually still not completely affordable to everybody unless they want to go the drastic route, which a lot of people need to and do, and go on like state insurance. But that in between gray area that a lot of people fall in, it can still be very expensive. And so there might be big copays, there might be big, what's it called? Anyway, I'm blanking on where you have to pay all this money before the insurance kicks in. Totally brain missing that. But so for health insurance, you can't necessarily assume that they have good health insurance that will cover their ability to get the care they need, both for mental health as well as physical health needs.
I think you mean deductible?
Deductible, thank you. That's a simple word. And also another thing that people probably don't realize is because I'm talking about all these other experiences, or they see in society how they're not fully accepted, or they've had negative experiences, queer women, LBQ women, and as research has shown this by lots of data, that they delay their care. So if they're not feeling well, they put it off because they're not really sure where to go. Who's my trusted person? I don't really have a trusted doctor or a therapist. And now I'm feeling bad. I'm now even more vulnerable. So I even feel more afraid to go see someone, and I don't know who that person is. So then their situation exacerbates. And if it's cancer, it might not be caught at stage 1. If it's, they start drinking a little too much, well, it might not be caught until it's gotten a little bit further down the road of addiction and all of the impact that could have on someone's life. And that's been shown time and time again with research, that there's delay in care. Again, the whole idea of the mental disorder with the DSM, just that type of having that out there still exists, and does impact some ways that they're treated, and so therefore prevents them from getting the quality care they deserve. Similarly goes with that hostile attitudes by providers. Could be verbal words, it could be nonverbal cues. It still happens a lot, and it happens actually often. I happen to work at Lambda Legal right now, and there are a lot of legal cases around people being denied access to health care. So, I mean, the hospital. So their partner is in the hospital, and they're met with hostile reception from just a basic person at the desk who doesn't really know who they are. But if, let's say a woman's in the hospital bed, you know this, right? A man walks up and says, oh, where's Maria Sanchez? They go, oh, she's in room 4. Who are you? I'm her husband. Okay, go right in. Don't even question. Can I see your marriage certificate? When does that happen? It doesn't happen, right? But Maria Sanchez, room 3. Who are you? I'm her wife. What? I'm sorry, what? And those types of things still happen every day. Sometimes they're let right in. Sometimes there's a little back and forth, and then they're let in. Think about that distress that causes the spouses. And then there's lots of times where they're denied, either because they just don't believe it, or they have phobia, the person who's at the desk or the nurse, and they literally block them from being there to support the person. And as we talked about, having really strong support really helps people to get healthy and to heal. And so those things still happen every day. So here's just some specific examples from case studies that have been done. The first ones, again, from my children's hospital groups that I ran, qualitative studies that some of the young women shared with their healthcare experiences. They said that with providers, one said that the eyebrows go up. It feels like a judgment when I tell them I'm attracted to women. They look confused when I say I'm attracted to women. I don't really want to tell a person with a needle in my arm that I'm attracted to girls because it's none of their business. So all those, what do those have in common? It's those nonverbal cues, right? And it's also about when and how do you talk to your clients about who they are, whatever that might be. Is that, if you are a provider, if you're doing some kind of vulnerable tests, this is a little bit more for medical people, but if you are drawing blood, or you are giving them shots, or you are doing a pap smear, that to the doctor and the provider, it's so routine, they forget often how vulnerable that is. So if you're doing that, and then you start asking them about these very personal issues that the people who are LBQ have experienced a lot of discrimination for, that's makes it even less safe for them to actually be who they are and share who they are. So you have to think about when you're doing it, how you're doing it. And another person said in a different study, if you can't be open, how can you trust your provider to help make decisions, right? So if I can't trust them with who I am, why would I trust them when they say, oh, you have type 2 diabetes, I need you to do this with your diet? Like, you all of a sudden, the LBQ person doesn't even feel like a partner with them. And so you've already lost them in terms of trying to help them live a healthier life. And I think there needs to be trust with my provider, and knowing about all of me, including my sexual orientation, helps build trust. That makes sense. Another quote from Latina and Black women study from Allison Saranzo, who's one of our steering committee members. Often providers aren't culturally responsive, so your care can be really horrible because you're really trusting in this intimate way. You're probably at a vulnerable point. If you're there's a power differential. So kind of a sum up of what I've been showing you. And this is actually from a woman quoting this, saying this. So power differentials, feeling very vulnerable. Again, you're there because you're not in your most powerful, healthy state. So you already feel, like I said, vulnerable, and you're trying to find someone to trust to help take care of you. how are they responding to you culturally, both in terms of your ethnic, racial, gender, sexual orientation, relationship status. That does inform how you're going to adhere to their treatment protocols, to their suggestions for how you should heal from whatever ailment you have. So the impact, some summary of an impact of discrimination is LBQ women are less likely to report receiving affirmative mental health services. Again, they're less likely to present for health care at the time when it's needed, so they delay their care and then their problems are exacerbated. They're less likely to come out to their provider, especially bisexuals, because I talked about it's so easy to allow your provider to assume if you are by chance in a relationship, if it's an LBQ woman with a man, that they're just assuming this, what's it matter? I'm having sex with him now. I'm not really having sex with a woman now. And yet, but without telling them who you fully are, again, you're not fully trusting them as your provider, so that you're going to actually bond with them to take their advice and let them care for you. And your provider is really not giving you the optimal care because they don't know all of your story and aren't fully informed about who you are. And LBQ women are less likely to have a consistent source of healthcare because what I said is that they don't know who to trust. They may just go into an emergency room or an urgent care or not really have an ongoing. Also, sometimes people will say that has to do with not needing birth control if they're not having sexual relations with a person who has a penis that can cause pregnancy. So that might be part of why there's not an ongoing relationship that some other women might have, et cetera. But it's also about the discrimination and the barrier to being able to find a provider that they trust over time. So therefore they don't go in as often. There we go. Half of LBQ women have experienced discrimination in healthcare. You can see all of our citations are in there at the bottom in the notes, and they're also at the back of this presentation. This presentation, by the way, is on our website that I'm sure is in the notes that Kara will be sending you and Frankie will be sharing with you. Quickly, my clock is not on here because I took it off. I just want to check my time. Hold on. Okay. Healthcare issues. I'm not going to spend much time on this because truly women's healthcare issues are LGBTQ women's healthcare issues. There's not much of a difference. It's more about who is this woman? And it's your job to find out every person's unique lifestyle, situation, body, and help them accordingly. But if we looked at research, it would say that overall, LBQ women tend to be smoke at a higher rate than heterosexual women, tend to be a little bit more overweight as a group than heterosexual women. And again, decreased access to care for all the reasons we talked about: insurance, lack of trust, lack of accessibility, lack of finding people who actually are respectful and educated providers for them. Similarly, breast cancer obviously depends on each specific person. But if you looked at the group, research would say that the later the childbearing, nulliparity, meaning never being pregnant, higher rates of smoking, heavier alcohol use, lower birth control, and lower just screenings is what increases your chance of breast cancer. In those categories, LBQ women tend to fall in a little bit higher rates than strictly heterosexual women. And so all these things we've been talking about is stigma and rejection, again, wears on people's mental health. The minority stress model, right? So these negative messages coming from the outside impact one's ability to thrive and feel amazing and feel powerful because there's these external messages and actual behaviors at them that are negative or discriminatory or cause you to feel invisible. And that sometimes can become internalized and you might start having your own negative messages. And so that contributes to that higher level of stress, might lead to depression or anxiety or just wear on your body. And so it contributes to physical, mental, emotional pressure, strain, tension. And research does show that, again, higher minority stress increases depression, what I just said, alcohol use, ways to, how do I cope with this? I don't feel good. I'm trying to find a way to cope. So again, why would mental health be a greater risk for mental health problems, LBQ people? Because of the internalized homophobia, because of the rejection and stigma, because of depression, anxiety disorder, because there might be, again, also some separation from family of origin, trying to find that community. I'm not sure who your trustworthy providers are. And just a little bit finer point that gives you some numbers from research, lesbians are 1.3 times more likely to have reported interpersonal violence. So that might surprise people. Bisexual women, 1.8 times more likely to have reported experiences of interpersonal violence than heterosexual women. So that's interesting. So you cannot assume, it's all about you asking questions, right? So you can't make assumptions that two women, there's less violence. Maybe, maybe not, depends on that couple. Going back to what I showed you in the Gallup poll, here we are again, this has been known for years, is that bisexual women not only are the highest number of women actually identify, that was in that Gallup poll that I didn't highlight, women actually identify more as LGBT than men, at least in a survey overall. And then bisexual is the largest category within the acronym. And then bisexual women actually tend to have a little bit more of the physical health risks. And they also have the higher mental health risks, which is even more interesting. I might conjecture that might have to do with they're even more invisible and there isn't as much of a place that they can identify with. But that's a conjecture that has been shown in some research, but overall it is clear time and time again that the mental health distress is greatest in bisexual women, greater than heterosexually identified women and lesbian, gay identified women. Youth, as you might imagine, homeless youth, the highest percentage of homeless youth are LBQ of all genders, T of all genders. As you might imagine, there's rejection by family often, churches, religions, excuse me, I shouldn't say churches, religions, organized religions, violence in families, school bullying. And so getting youth to disclose, which is happening more and more, as we see in the Gallup poll with our newer generations, helps them to find support and to actualize and stay a little bit more on track with the developmental stages. But there is still so, as we can see, all these backlashes in these states, right? I mean, it's getting even more like we're having a very severe backlash now. Think about how that's going to impact youth and how it's going to set them back both in their development and their health and their safety. So we already talked about this, but really quickly, again, there is research that shows that lesbian and bisexual women are more likely to use alcohol, drugs. They even are now doing vaping studies. And as we know, all these companies also, I don't know if you know this, they target the queer community. They've been doing that for years because they're vulnerable. And because these are coping mechanisms to sort of ease the feelings that they have, the negative feelings from the stress that they're getting from external negative impacts. So that's just basically saying that it's greater. So sexual transmitted diseases, infections, I mentioned that earlier. Don't assume that people are at less or higher risk. It really depends on really physically, what are the sexual activities they're having? That gets back to the difference between orientation, identity, and behavior. I used to work in HIV and I literally taught hundreds and hundreds of people, if not thousands, probably thousands, around how HIV is transmitted. And it's very mechanical in a way. It just depends on what fluids are exchanged and what body parts are there to make the exchange of fluids more efficient. And obviously there's needles and so forth. But in terms of sexual activities, it's not so much about the orientation. It's not who you're in a relationship with. It's what you're doing. And so people who are women who are with women, cisgender, lesbian, let's say they are still susceptible to STIs, but it really depends on what people are doing. And again, we can't assume that someone comes in with one partner, that's their only partner, especially for the last year or 18 months and so forth. I'm talking really fast. I apologize, trying to squeeze this all in. Same thing with parenting, no assumptions that people will be parents more and more and more and more. LBQ people, LGBT people, as I just described with my colleague, are parents one way or another and are planning a family together. So no assumptions there. It's all about researching who's this person in front of me, who are they, how do I get them to trust me, how do I give them the best possible care. Also, let's not forget older people. So we talked about youth. There's older people who are 80, 90, 70 who are LGBTQ and who, if they're two women, historically, women make less money on the dollar, and white versus Black versus Latina versus Asian, et cetera, Native American, all different levels of how much sense they make on the dollar to the white cisgender man. So as a result, if you have two people who make less, guess what? Their overall income, their social security benefits are going to be less. And so they start off at a lower place once they are no longer working. And they might also be higher discrimination for being hired. We also know that AARP does a lot of studies on the older people get, the harder it is for them to get a job. And so we have to keep in mind that then impacts their health insurance, their ability to go access care, even if they have health insurance because of the deductible. And they may also be used to hiding and being in the closet. And so again, being open, being trustworthy. And then this is an important part. I alluded to this earlier, is if you do have older clients, talking to them to make sure they do have advanced healthcare directives that they literally carry on them. They put in their electronic health record or in their file with any provider that they do have, that their partner or spouse has it on them, because there is an assumption that so the brother who hates the wife of his sister often, still to this day, not as much as it used to, will step in and the providers will listen to him because he's a man who's taking care of a woman as opposed to a legal wife. You think that's not possible. It's possible. So that's why you need these legal documents to say, no, excuse me, I am the legal beneficiary. I'm the legal spokesperson. Here's the advanced healthcare directive of my wife, Anita. Here's to prove it. It's in the record, etc. So those types of things are very important. And actually federal regulations do require that any hospitals that get federal money, depends on who's the president, but in this case, it is more of an executive, it's not a congressional law. It's more something that's controlled by the administration. But usually the federal regulations require anyone who gets federal money, which is most hospitals, they have to allow whoever you state is your primary support person to be allowed in and to be your support person, though that law is broken or that mandate is broken all the time. EHFs or EHRs, sorry, or EMRs, medical or health records, are important as well. Also, if you still have like paper forms, what are the questions you're asking? What's the language you're using for the questions? How open-ended are them? What are your options around sexual orientation, activity, relationship status, gender identity, sex assigned at birth? And also, what is the language and what are you offering in terms of visuals, in terms of educational pamphlets in languages that are attractive to people of different ages and races, orientations, genders, literacy levels, etc. All things to think about in your workplace, in your practice. So I think we're almost at time. This next section is about communication. It's really just about, and I've said it over and over, how you present yourself as an open, trustworthy practitioner provider is what is going to be the difference between your client, no matter what their issue is, trusting you, opening up about really what's going on so that you can provide them with the best possible care in whatever capacity you're supposed to do that. I came up with this over the years of training, from my master's degree, as well as all of my training over the years, is this idea. I say a silly phrase. I say it mostly to doctors because they're always rushing. I have a picture in my other presentation that says, when you open the door, engage your core. So remember, when you go in to see that provider, when you go in to see your client or your patient, take a pause. You just had a fight with the nurse, or the lab got your thing wrong, or your wife just called you as you're going in to see a patient and you're like on your 20th patient, you got 15 minutes. Your job is, with that person that you only have 15 minutes with, is you got to be caring, open, respectful, empathetic, because that's how you're going to get the truth from them. You're going to learn what's going on with them. And as a provider who's dedicated their life to taking care of others, you really want to provide that good care. But unless you are open and you're a good communicator and you're presenting yourself in a trustworthy way, those patients, for various reasons, will shut down and not let you in. And then you're really not going to provide optimal care. So I provide some, not me, we provide, this is a collaborative that's developed this, and we've honed it, we've revised it, we check this out all the time, our presentations. It's a very basic presentation, but it gives you some basic suggested phraseology that if you want to, like, how do I bring up pronouns? You could just say hi. For me, I'd say, hi, my name is Dr. LaVaccare, and I use she, her pronouns. How about you? What's your name and your pronouns? What do you know, they'll answer. Some people are like, I don't know what you're talking about. Most people these days have heard about pronouns and they'll just answer or not. But those people who are looking for those pronouns will hear that, and gosh, will they appreciate that. And right there's such a huge cue to them that you are trying at least, and that you're educated around those issues and that they might dare to share with you. And then the other idea of mirroring what I said this at the very beginning, what label do they use? How do they call their spouse? What do they talk about themselves in terms of gender or sexual orientation? And then you can mirror that back. Or if you're not sure, you could say, well, I just heard you talk about blah, blah, blah. Can you tell me more about that? Or if they say a name of somebody as their partner, you could say, can you, they might say Jan. You say, well, can you tell me a little bit more about Jan and like, what's your relationship? Because you still are trying to find what's the gender of that person, what's the nature of that relationship. But you can, if you have to go somewhere, go and mirror what they said about themselves and use that same language. So this is just basic nonverbals. It depends who you are, if you need this training or not. I was just earlier today talking to a bunch of more social workers, and they didn't need this training, whereas doctors and nurses might. But the idea of, if you've never heard this stuff before, and we talked about it in these quotes that we got from LBQ women, is that the nonverbals, they're watching out for that, as also with people who are racial minorities, et cetera. They're hypersensitive, we're hypersensitive in watching. So if you're not familiar with some of this stuff, without meaning to be harmful, you might pull back, you might look puzzled, you might be, and the patient is going to read that probably in a negative way because they come in with glasses of being harmed or discriminated or misunderstood or invisible in other places. So it's your job to practice that ahead of time, sort of get a sense of what your facial expressions are, what your body language is in general, and try to make eye contact, try to have an open physical stance, try to be neutral or pleasant in your facial expression, have a personable tone. Again, follow the patient's lead, let them be the leader, opening and asking open questions and giving affirmations, and also giving explanations of why you need to ask such questions, so they don't think you're just randomly being curious or invasive. And also reminding them about confidentiality. So the things not to do, again, would be crossing your arms or pulling back, or again, asking them sensitive questions when you're doing an invasive procedure, or turning away from a patient. Doctors often do this to save time. They'll be on their laptop and they'll go sit down and they'll try to keep it going because they have such short time. But if you're trying to share something really personal or vulnerable, that patient and client is very likely not going to tell you at that time because they don't have your full attention. They don't even really know if you're listening, and they can't get the cues from you to know if you're trustworthy as you're disclosing. So try to be, again, facing that person. There's always exceptions in certain cultures that might not be appropriate, direct eye contact and so forth. But for the generality in the United States, you can sort of start with these. So again, I brought this up earlier, but remove distractions, make sure you're in a private location. Don't start a conversation in a hall room. Don't start a conversation in the parking lot. If you think I don't have any rooms to go to, it's still not okay to try to talk about anything with a client or patient that could potentially lead to them wanting to share personal, vulnerable information if you're not in a one-on-one setting where someone might overhear it, because then they're not going to talk about it. They might even directly lie, because that's way safer than disclosing something that someone else might hear that they're scared for them to hear, because that could cause them lack of safety. Again, try to maintain a very supportive, non-judgmental attitude, asking open-ended questions, checking your body language, like I said. And here's an important one I've alluded to: ask for clarification, open-ended follow-up questions. So I heard you say this, can you tell me more about that? Or, when you said this, I'm not really 100% sure. I want to just check in with you because you know you best. What did you mean by this, etc.? Or I have to add, I'm going to get to this now, and then don't ask gratuitous questions that really don't have to do with their care or their best practices, because you just want to know. You go find that out from your supervisor, you go look that up, you talk about that with your colleagues. Use affirmative language, mirroring what they say. Again, reminding yourself to not use negative terms, as someone brought up earlier, which is really good, that their questioning is queer, positive or negative. So know that about your own language. Be respectful, again, of their choices and try to mirror what they say, pronouns included. And you might mess that up, and it's okay. It's not, it's not ideal, but if you do, tell them, I'm so sorry, and just correct yourself. So if they say they, or they say there, and then you follow up with they, and you go, I'm sorry, I meant there. They're going to be like, okay, this person is trying, I got it. I hear that, and just keep moving on with an apology. And if they want to talk about it, they will. So again, focusing on behaviors and practices and not assuming what those are based on what you know about their relationship status or their sexual orientation when you're discussing sexual identity. And don't assume heterosexuality, which means don't assume they must have a pregnancy test. That's one thing that comes up a lot, even though that might be a liability protocol for your hospital. That comes up a lot, is that people often feel like they're like, it is impossible that I am pregnant. And they'll be like insistent on a pregnancy test instead of asking, can you tell me about why you're saying that you wouldn't need this? And they'll explain it to you. And then you have to say, some cases, like I said, it's literally the rule of the hospital that they must have one, because for the most part, women are having sexual relations with cisgender men, and so they might be a chance for pregnancy. And then I'll bet you most cases, not all, but most cases, if you explain that after you talk to them, say, you know what, this is just a general thing, and it's because of this reason, most people will go, I get it. I don't think it's right, but I get it, and I'm not holding it against you, and I'm still going to be able to bond with you as a trustworthy provider. But just inquiring further and explaining to them what's going on. So again, inquiring about the genders of their partners, not making an assumption by a name or so forth. And then don't assume if they tell you about one partner that that's their only partner. And I have some questions that you can use to sort of get to that. And I'm sure that follow-up fact sheet will have those as well, because we have that on a separate form. Again, what I just said about birth control. And again, you make mistakes, just apologize. Do trainings like you're doing now, which is amazing. Again, posters, pictures, etc., that people know that you're open to serving everybody, altering the forms, which I already said, so that they see themselves in the questions asked right off the bat when they're sent to their home. Say, here's an intake form. Will you fill this out before you get here? They're already assessed you. Can they trust you or not based on what you've asked in your EHR? And then if you want, you could advertise in the local press, social media, whether it's LGBT or not, and just put your whole general, we accept and we support everyone, blah, 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 you know, every race, every gender, every sexual orientation, every economic status, blah, 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 blah. And that goes a long way if you have that in your budget. So you can make something like this at Children's Hospital. I made a poster. We got consent from some of the youth. We took pictures of them. They gave waivers. We wrote a statement like this, and then we put a couple pictures with some of our providers, some of our youth, and we hung that up in every doctor's office and in the lobby. So if any, no comment, and people see it, and they understand this is a place that accepts everybody. So if you can't afford to buy something, you could just make one in-house. So again, key concepts, bias reduces access, right? So having discrimination experiences and provider bias does reduce the access and quality care for LBQ women. Try to make sure your environment and language promote the comfort and project acceptance for sexual and gender diversity. And understand, again, the community and family role in people's lives could be a positive and it could be a negative, right? So you can't assume one or the other. And LBQ women may face certain health outcomes that are a bit different than heterosexual women, but best bet, just find out about the individual person in front of you and what's unique to them. And I think I'm basically, here's just some basic summaries, is that you can use these types of language. In order to provide you with the best possible care, I need to ask you some questions about your sexual history. So that kind of gives them like, why is this person going down this road? And then this is kind of one to let them know that you know it's sensitive. I'm going to ask you a few questions about your sexual health and sexual practices. I understand these are very personal, but they're also very important to your overall health. So sort of starting off that way. So they're like, why did they care about blah, blah, blah? I asked, or they also like, why are they asking me this? This is another way to open up and say, I ask these questions to all my clients. Like the rest of our visit, everything we discuss here is confidential. And then you go into the very sensitive questions. And then if we're asking specifically about sexual behavior, you can say, I know these are sensitive issues, but to learn more about what may cause your symptoms, can you tell me in the past 12 months, if you've been sexually active with anyone in any way? And that way it gets beyond like men, women, or both, or one partner. And so if they say blah, 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 and you say, okay, thank you. Is there other people that you've been sexually active with in any way in the last 12 months? And then they'll say, oh, well, there was this one time. Say, okay, great. And you might inquire about that a little bit. And then you'll say, okay, is there anything else you want to tell me about anyone else you've been sexually active? And you could just keep going until they say no. So they're open-ended, but they help people to understand why you're asking. I think that's good. this is just a client scenario you can look at later, and I think we're a little bit behind time. Is there
Right.
any question?
I think, yes, we're going to need to wrap up, but
Yep.
if there is any burning questions that anyone has, feel free or comment. I had one I wanted to just ask Sue, and that is if LGBT woman is not getting sensitive care, what would you advise her to do with a provider? Because if she's there and wants to get decent care and it's not happening, what would you advise her to do?
In the moment,
Mhm.
well, I mean, there's a couple of things. It depends. I mean, you could be open. And I honestly have had this happen to me myself, and I'm like a professional LGBTQ health person. And sometimes the providers are biased and phobic and discriminatory, and you got to get out. So one might be is you need to know when to take care of yourself, because that person is just not going to get it. Sometimes it's, again, disclosing more to help them to understand. Other times it might be, which is not very practical. So the reason I'm hesitating is it's very impractical to say, like, can I see someone else? Because in healthcare provider settings, there's appointments. You could say, I'd really prefer to be seen by another practitioner, or is there anyone else available, or I'll wait for someone else, or I'm not feeling comfortable with this. Is there someone else that will be available in the next 15 minutes? So you could do that to stay there, to be persistent. Obviously, if it's around being there in the support of somebody who is there getting care and you're their supporter, that's where the documentation and the persistence comes in. But there are definitely scenarios where you have to take your safety and leave, and then you report that. Other ways would be, which I think people do in general, like you vet your providers, you try to prior to going. But I think the biggest thing would be, but it's not easy to say. So that's why I hesitate as well, to ask the woman to be the one who is the big assertive one, who's the one who keeps saying, but let me tell you, this is who I am. That really shouldn't happen. It should be a two-way street. But obviously trying to be as open as you can upfront, to give your provider, to be a good partner as the client, so that you are providing with all the information, so they do know who you are, so they have an opportunity to meet you halfway. That's obviously would be the ideal. But of course, as I said, there's a lot of reasons why people don't do that beyond just sexual orientation. So, but sometimes, like I said, you do have to leave and then you report it. And not that that matters, but if there is a case like that, let me tell you, Lambda Legal has, it's called Legal Help Desk at lambdalegal.org is the email. And there's also phone numbers on the Lambda Legal website that you can call all over the country if you do have anything that you feel is illegal, and they will either help you directly or give you resources if you had to go that route, which is a more drastic.
Wow, great, thank you. Any other quick comments or questions?
I think people are much more educated. You're welcome, everyone who's saying thank you, and thank you all for the deductible. I appreciate that. Yeah, we're available.
And there is one question. Excuse me, Sue.
Yeah.
Jasmine has her hand up.
Oh, go right ahead, Jasmine. I'm sorry.
Hi, Sue. Thank you so much. My name is Jasmine. I'm actually currently a nursing student at UCLA.
Okay.
And I was wondering if I could just get your contact info, because I think it'd be really amazing to get like the healthcare provider training to our students, just as they're currently in the clinical settings. And I think this would be something really important, because I don't think this topic is, I'm almost going to graduate and we haven't had like a specific training, or even I would say like our class content doesn't even cover how to address this like population. So I think this would be really helpful.
So I just put it in the chat. That's mine. Frankie also has Kara's and Julie's, but I can take your information, circle back with them, and set up a time. And what you just said, maybe I didn't say it with this group, but I said it with the earlier group, is it validates that in most medical and nursing trainings, if it's at all still addressed in 2022, it's 1 hour of one course throughout their entire training. So yeah, we're glad to thank you for that. We're glad to do that. I've trained lots of nursing students over the years. Anyone else have questions or concerns or want further resources? That's my email. You can also write Frankie, who will give it to Kara and Julie. And look at our website, which is, I don't know, Frankie, you have that in the
Yes.
yeah, okay, yeah, it's just it's on the LA the UCLA Iris Cantor website holds our LA County Lesbian, Bisexual, Queer Women's Health Collaborative web pages. It has all these PowerPoints on there. But yeah, Jasmine, it'd be better if we present it for you to give it a little bit rich context. Glad to do that.
Wonderful. Well, thank you so much. And thank you to everyone who has stuck it out to the end. But it's really was a wonderful presentation, Sue. You're so clear and to the point. And even those people, I think, who have a lot of exposure to it, there's always new things to pick up. So we're really grateful. And I'll turn it over to Frankie for the last word.
Thank you.
Yeah, so thank you again, Sue. And thank you everyone for joining us. I will be following up with an email where there will be a link to the survey that I posted in the chat a little bit earlier. And I will also provide Kara's email if you want to schedule a presentation for one of your groups as well. So thank you and enjoy the rest of your night.
So Frankie, before you turn this off, can you see that there's a email request to send the presentation? If you could just send them that link of the website.
Oh, okay. Yes. Thank you.
Thank you. Thank you, everybody. Take care.
Thank you so much. Really grateful.
Thank you.